I'm going to do this morning is just focus on the workforce of the future, and individual perspective. My starting point postdates the system, and I think it's very important to take account of Robert Francis's report and Don Berwick. If you remember, Don Berwick was commissioned by our Prime Minister to actually look at the NHS and its workforce. And Sir Robert Francis made a great emphasis on education and training and the need to integrate essential shared values of quality of patient care in the culture of the NHS. And then Don Berwick made in his recommendations the very important point that the mastery of patient safety sciences and practice should be part of the initial preparation and lifelong education of all health professionals. And that means from day one in university to the time that you retire. My thesis for today really is that have we really addressed that for the health professional workforce? Two reports. The one on the left is the Darzi report. That was the NHS The Next Stage Review. And many of you have probably forgotten it. Can you remember the date? I had to scratch my head, but I went off to Cambridge because Darzi went around the country. It was 2006, 2007. It seems an eternity. So that was the era of polyclinic. But actually what was within the high quality care law was not so different from the 5-year forward review. Both were proposing a very radical reconfiguration of the NHS. Both were proposing integrated care. And actually it's quite interesting, the Next Stage Review was the first NHS review that actually had a section on the workforce. Incredible, since 1948. No one really had addressed the workforce in its entirety. There have been individual reports on individual professions, but Darzi brought it together. And that's very much the case of the forward view, the 5-year forward view. And what I'm going to focus on is how we integrate that training for the future healthcare professional. So I'm going to talk about integrated care, something that's very dear to my heart, because I started my consultant life as a jobbing physician in Europe. I was a senior lecturer at the London Hospital Medical College, but I was actually a diabetologist appointed to something called a district health authority. Do you remember district health authorities? And I had admitting rights to Newham General Hospital. So I actually had, I had a firm, as we used to call them, within the hospital, but I had a community diabetes team. And it was at the outset of diabetes specialist nurses. And we not only had nurses, we had podiatrists, we had dietitians, and we were based in the community. So we had one of the first diabetes centres out with the hospital setting. Indeed, just before I left, we had the first sort of purpose-built and design one in London. And it really brought home to me that integrated nature of working with and across the professions. And that included general practitioners and the primary care team. We called the system of care delivery for diabetes as a shared care system. And I like the term shared care because it actually implies for the patient is at the centre and the patient care is shared between all the health professionals. My slide had Ken Clarke in the corner. And of course, I'm sure no one else, but I went to the London Docklands in 1989 when Ken Clarke was then the Minister of Health, then we used to call him Minister of Health, launched the purchaser-provider split. And the impact on me in Newham was that my diabetes team went into the community and I had to go back into the acute sector. And never was it quite the same again. Go forward 2015. This is the patient I saw in the diabetic clinic 3 weeks ago. He's a person with type 2 diabetes who was found to be anemic, referred to the hematologist. The haematologist investigated him and found it was the anemia of chronic kidney disease. Actually, I'm not certain why he was referred to the haematologist. He was referred to the nephrologist. He was treated with erythropoietin. He had a stroke. So he was referred to the neurologist, the stroke team. He recovered from his stroke. Of course, he was still anemic. He was referred back to the haematologist, who said, quite rightly, chronic kidney disease, referred back to the nephrologist, who wanted to give him erythropoietin. The patient refused. He then required a transfusion, went back to the haematologist, came to see me and said, who's looking after me? And my purpose for showing this is that I'm afraid that this patient is not unique. And it's really, when we're talking about training a workforce, we need to talk about training a team. It's not an individual, it's a team of health professionals. And in a way, it's a jigsaw, and I'm afraid I don't think we've got the pieces together at the present time. We've got all the right notes, but we're not playing them in the right order. And I do think it's so important that we really do begin to think about this as we look to plan a future workforce. Training is the fundamental element of the future workforce, not just simply at a university level, but through the whole of the life career of that individual. And it is that teamwork thing. I'm afraid we do, to a certain extent, from a training perspective, play lip service to team working. I'm afraid, here at St George's, we put pride in our interprofessional working, but it's actually at an undergraduate level, I'm afraid it's tokenism. We need to actually put it through. For our medical student, it's 5 years. For a nurse, it's 3 years. Every opportunity we should take to bring the professions together, because it's cohesion, communication, collaboration, cooperation, coordination, which will lead to the best patient care. And if you look at the definition of cohesion, can be more specifically defined as the tendency for a group to be in unity while working towards a goal, or to satisfy the emotional needs of its members. I think that actually defines the sort of health professional team extremely well. But how cohesive is our training at the present time? And how cohesive, if you go back to my case, how cohesive is the way that we deliver care presently? And we need to look across the boundaries, which takes me back to Newham, because it's not insurmountable, despite Ken Clark. That purpose, that integration of care, we've got to get across. I hate the term primary and secondary care. There's no such thing as primary or secondary care. There is health care. And it's just simple definitions like that seem to produce bridges and barriers to care. So that's another aspect that we need to take account of. And it also then relates to the experience of that new nurse, that experience of that new physiotherapist, that new pharmacist, that new physician, in understanding the different elements and environments of working within a health service. So my question is, do we need new types of health professionals? We've seen a lot of new types of health professionals. Or do we need to establish established health professionals taking on new professional roles? And of course, there are very good examples of that. Now, this is a slide from the HE workforce plans. And the reason I show this is that there are a large number of health professionals working in the service at the present time. And indeed, if you look at the increase in the health professional workforce within the NHS within the last decade, it's quite staggering. This is percentages, I hasten to add. But if you look at the number of consultants, if you look at the number of nurses actually in percentage terms, the only decline is in healthcare scientists, and that's largely related to advances in technology. But we probably need more healthcare scientists. And the problem is, we need more nurses, but there is a capacity issue. Are the nurses out there at the present time? And every trust is really challenged from a recruitment point of view. So it really does mean talking about roles and working more as teams. It also talks about how we retain those health professionals within the NHS, but that's, in a sense, another story. So what I'm suggesting is that we need, and we are, blurring the disciplinary boundaries. And there are good examples of that. This is from the BBC website a few months ago. Are nurses the new doctors? No, they're not. But of course, they are taking on roles that were formerly undertaken by doctors. And as I say, going back to my diabetes experience, the first specialist nurses were in diabetes, but there's mental health. It's every specialty now has such individuals. The second point, the pharmacist, the extending role of the pharmacist and the expectation for pharmacists to take on new responsibilities. But actually the question I ask is, are pharmacists trained to take on those responsibilities? No, they're not at the present time. They need to be trained for the future. But that also, and you'll hear from Karen, does create tensions. The physician associate, and I challenge anyone in the room to say, why do we need physician associates? Well, we do need physician associates. We need to support patients, and it's a very different role and a new role, and it's supporting medical as well as other health professionals. But then there is this thing, well, it's producing doctors on the cheap. No, it's not. It's a different role. So we need to think about the jigsaw puzzle and how do we train appropriately. And I think that's really challenging. Again, this is from the HE publication about the workforce, and it talks more about the individual's personality to work as an NHS professional. And I think it's fine. No one would argue with what is put on the slide. I'm not going to read it all out, but it's about individuals' perspectives and their values. However, for planning a workforce, sometimes we forget that the starting point is the patient. And I'm a great fan of William Osler. Okay, he's talking about physicians, but it's just as relevant to the whole of the health profession. It is much more important to know what sort of a patient has a disease than what sort of a disease has a patient got. So we start with the patient and the family. And you then, I think sometimes we forget what is the characteristics of good health care. And I actually, talking to Emma, I suddenly realized I didn't list mental well-being on it. So I'm sure we can extend the list. But it actually, all of the things that I have listed there, whether it be nursing, nutritional, physical, spiritual, diagnostic, therapeutic, recovery, prevention, is in the interest of every health professional. Why do we say, well, therapeutic is the doctor, nursing is the nurse? No, it's not true. It's over the whole professional team. But there are elements that people are more expert in, whether it be nursing care, whether it be physical, which I would suggest in the sort of the physiotherapist, whether it be the therapeutic, and so forth. But working together as a team, you address that patient's situation far better. And then there's the family care, and really you're dealing not with an individual, just an individual patient, you're dealing with their family and their carers. The other important aspect, and that goes back to my patient and the reason for showing that slide, is the overall care. There's the leadership, the management, and who takes responsibility for care. And too often in the modern health service, responsibility seems to be passed from one person to another, with the patient not knowing who at the end of the day is looking after me. So that's the challenge for a workforce for the future. And that is in a very challenging environment, because we cannot deny the increased demands on the service and, in real terms, serious budget cuts. And the problem with both of those factors is that we look for quick fixes. And actually, it's not so much we look, we are required to find quick fixes when we need to be planning for the longer term. And I appreciate that's the real challenge. And I'm a great fan of Groucho Marx, and I think in the health service, we'd rather, the secret of life is honesty and fair play. If you can fake that, you've made it. In a way, we've slightly done that within the health service over the years. Again, this is from he. This is actually for this year. It's planning for current staff shortages within future training supply decisions. And no one would contend or argue with this block, which actually says, agency bank use, temporary, permanent, and so forth. But unfortunately, it's a stopgap. So how are we going to plan a workforce for the longer term? I'm not going to give the absolute solution, but I do think it is important that we train for now and for the future. I mean, everything we sort of think about is taking account of what the immediate pressures are, but what the longer term requirements are, taking account of how the delivery of healthcare has changed enormously in the last 2 decades. So go back to Don Berwick. The mastery of patient safety sciences and practice should be part of the initial preparation of lifelong education for health professionals. So for a moment, I'm just going to talk about those within the university sector and the responsibility in universities that we have. And I'm talking across all the health professions. The biggest challenge, and I've had a lot of experience in this, is the curricula. Oh, it's all too difficult. We can never get them together. Oh, you medics are doing this and the nurses have to do that. Actually, it's not so difficult. I do appreciate there are vast numbers, but actually if we were a little bit more innovative and imaginative, and we have 5 years for a doctor, we have 3 years for a nurse, we have 3 years for a physiotherapist. There are opportunities to bring the professionals together. And it's absolutely crucial. For the brave, nothing is too difficult. Because tribalism sets in health professions in week 1 in university. And unless we address that, it's there for the remainder of the career. And you quite often, my wife and I had a conversation last week with some colleagues in Cyprus, because we have a campus in Cyprus. And the impression one got about the nursing professions, you thought were back in the last century. And that's because how they were trained. The other is, and again go back to William Osler, observe, record, tabulate, communicate, use your 5 senses, learn to see, learn to hear, learn to feel, learn to smell, and know that by practice alone you can become an expert. That is so relevant to every health professional. I believe we have real opportunities. And actually I have to acknowledge Health Education South London and HEFCE, because we were given a grant this last year on the 2 floors above here to create what we call a low fidelity simulation centre. And that provides the space to simulate what might be a patient's home, what might be a hospital ward. And we put a pharmacy in there as well. So there are opportunities to actually start at a very early stage in bringing professions together, but with the challenges of the curricula. The other is in clinical practice. How often do we take that into account? And I think the opportunity for us in South London is that we need to be more imaginative about how we can put tasks together to bring the professions together at an undergraduate level. It's just as relevant at a postgraduate level. So developing scenarios around patient care. I've had experience in the past. Now, unfortunately, they were all diabetics and they all had the most awful complications. You have nurses in one corner, you have medics in the other corner, you have pharmacists we used to. And they start in their corners with the same scenario. By the end of the morning, they're working together as a team, and it's fantastic to watch, because the docs know quite a bit about the diagnostic and the sort of therapeutic interventions. They know nothing about the nursing and the care of the patient and putting up the bags and so forth. The pharmacists, of course, know a lot about prescribing and the writing up of the prescriptions. You start early. You actually see real benefit in students. And some of the others, here at St George's, there are some wonderful patient stories. Well, they're actually quite moving and awful to watch. Patient stories about adverse events within the trust. We've used them on occasions for students from across the professions, and I have been increasingly impressed by the way the students respond to those. And finally, utilising serious untoward events at an undergraduate level to understand about where things go wrong and an appreciation about the importance of teams in relation to that. And that, actually, again, is not just the hospital general practice, the mental health elements of it as well. It actually brings learning alive. And the other aspect is we have community education provider networks. And I'm not certain how much we're really thinking about the opportunities they will provide for the multidisciplinary learning, both at an undergraduate and a postgraduate, and it's across the community. It's not just primary care or secondary care, and I hate those terms. It's bringing people together and to learn. And that's how we will develop the workforce for the future. So we have different clinical settings. The other aspect that concerns me is it's the lifelong learning and the importance of generalism, the importance of looking at the whole patient and not a system. And my criticism of medical undergraduate training is it's become too system-based. So you learn about the gastrointestinal system, and then of course you have to go on your gastro-firm. Most patients that we now encounter in primary and secondary care actually have more than one system that has gone wrong. And so you need the generalist, whether that be a nurse, a doctor, or a physiotherapist, to understand the totality of that patient's condition. This is a slide that simply shows the sort of the road from medical school to retirement, emphasizing the increasing experience and skills and knowledge. I did it for medicine, but actually, I then did it for nursing, I did it for physiotherapy, I did it for pharmacy. It's exactly the same, which argues again, why are we not taking more opportunity to bring people together, to learn together in teams rather than as individuals? And if you tell me we are, then I'm delighted to hear it, but my experience suggests we're not doing it, or we're not doing it sufficiently. So it goes back to that team working and that term cohesion. But it also is important then to appreciate and understand and define the roles. There are certain things that the nurse will bring to the team. And I would never wish to undermine that. I think it's incredibly increasingly important. There are certain things that the medic brings to the team. There's certain things the physiotherapist brings to the team. My son is a physiotherapist, and I increasingly am impressed by his knowledge of the mobility and rehabilitation of a patient, the importance of getting them up as quickly as possible. And then the pharmacist as well. It's all a team approach. We blur the boundaries, but we don't actually lose those boundaries. We recognize the importance of that skill set. And I think that's really quite challenging, because the patient suffers. You know, if the nursing care is not absolutely focusing to a certain extent on the nursing care, then the patient will suffer. So it's going back to those points, and I will include mental health within that. But in truth, how much training actually occurs together at any stage, whether you be an undergraduate or a postgraduate, whether you be in training as a postgraduate or whether you're an established healthcare professional. And until we really address that, I don't think we can devise or develop our workforce for the longer term. The other aspect is so much of training is a bit like your sat-nav. You put in your destination and you follow the instructions. Whereas actually the best training is the one, in a sense, is partly self-determined, but it also is much more flexible and takes account of all the other professions, which takes me to the bit about advanced practitioner. So often it means specialization, when I would suggest it's much better understanding of generalism a better understanding of bringing the components together about a patient's illness. I've said it already, I'll say it again, how much of postgraduate training is truly joint. And what we need to do is introduce a bit more dynamism into the sense of how we train. And what I'm suggesting is we step back and we look and we say, what do we do well now? What should we be doing better to bring the professions together? My final point was there is a lot that we could do utilizing the information we have. I'm on the trust board here as a non-exec. One of the issues you see is falls in the wards. So I thought, I'm going to look into this. We have a heat map of particular, of all wards, but particular wards where you see that there is an increased numbers of falls. It's quite interesting. You can actually anticipate which wards are those with the older patients. But then when you begin to dive down into the reasons, mental state, sensory perception, physical mobility, feet, shoe wear, and increasingly polypharmacy. And patients on large numbers of medications, and then of course in hospital the doses may change, they are drowsy, they fall over. It's a perfect platform to get teams together on a ward and say, let's just look into this. Why is this happening? And I bet it doesn't happen. So my point is that for the future, there needs to be much more cohesion in training. And importantly, that leads to cohesion in practice. It's been a sort of a bit of a bus journey for me. And hopefully it hasn't come to the terminal as yet. But my sort of conclusions is that firstly, when we're talking about the workforce of the future, let's start and finish with the patient. Secondly, let's blur disciplinary boundaries. I think that's happening, but let's better define the individual's role. Thirdly, multidisciplinary training starts at the undergraduate level and continues to the day of retirement. We need to utilize more effectively the simulated and actual clinical settings, both at an undergraduate and a postgraduate point of view. We need to continue to focus on frequent and common clinical issues, those events that are happening every day, and address them as a team. And we need to ensure that generalism is a theme that permeates throughout every training program and career. You may well be a super specialist, but you still need to have that generalist approach if you're going to give the best care to your patients. And I close with the modern day Hippocratic Oath. For both the joint faculty graduation ceremonies and for the St. George's medical graduation ceremony, I always read at the end, before we congratulate them for the final time and send them off, the modern day Hippocratic Oath. Just take a couple of minutes to read it, because I think it is so pertinent to the workforce for today and for the future. Thank you very much.